Can you hear and see me?
Yes.
Yeah.
Okay.
Yes.
Any questions or concerns?
I just have a question about the chapters that are due. So the ones listed on D2L and the ones listed in the McGraw-Hill, they're two different dates. So I'm
Okay,
just
so
confused.
which, okay, so there, I'm pushing them back because we are behind.
Okay, it was just
on-
chapter 12 and 13. I think 12 is due tomorrow, which is
Yeah.
fine.
Yeah, I think
It's
they were
just
due on the
showing,
same day. Like
It's
13 due on the 10th as well.
yeah, it's just showing different days from D2L to the actual on McGraw-Hill. So I just wanted to clarify.
Go with what McGraw-Hill is telling you.
Okay.
I don't know why they're different. I think it might take a minute to load. Are they always different? Or are they just different today?
Let me look. I just noticed it now, so I'm not.
You may not be able to get into McGraw-Hill right now. Let me tell you, I just tried a second ago and I can't get in. There's a lot of internet outages and I'm wondering if that's why.
Yeah, it let me in.
Oh, see, you're just special because it won't let me in.
So, let me see. So like chapter 13, no, let's just do chapter 12 quiz in McGraw-Hill for the Gettysburg says it was due September 5th. Oh, no, wait, no, I lied. It's due November 10th. I'm looking
Okay,
at the
I was
start
like,
date.
what?
Okay. Okay, now I see. I'm sorry. I misread.
You're okay. You're okay.
Okay, so they're all in November. Okay, we're good. I'm sorry.
Okay. Yeah, I almost had a heart attack right there. All
I
right.
totally misread. I read the first date and I was like, wait a minute, we're in November and it was due last month. So never mind. Sorry.
That's okay. I understand. I understand. So let's get started. I'm gonna try because we're behind and we're behind my other two classes. So I'm gonna work to see how quickly we can get caught up. So bear with me here. I'm gonna see just how much of chapter 13 I can make it through here. So we were about right here. So back up just one slide here. So spinal cord is a cylinder of nervous tissue that arises from the brainstem at the foramen magnum of the skull. It has about 100 million neurons. In addition to those 100 million neurons, there's about 50 times more neuroglia. And so what would that be? About 50 trillion neuroglia. It extends from the medulla oblongata to the conus medullaris, medulla oblongata in the brainstem, to the conus medullaris, which is the tip of the spinal cord. It occupies about the upper 2/3 of the vertebral canal. The vertebral canal the reason it only occupies the upper 2/3 is because the vertebral column is going to grow faster than the spinal cord. And so the spinal cord only extends to about L1 on adults, the lumbar vertebrae number 1. It gives rise, the spinal cord gives rise to about 31 pairs of spinal nerves. With each pair, part of the cord being supplied by a different pair of spinal nerves called a segment. In addition to the 31 pairs, there's 2 enlargements. The cervical enlargement is going to give rise to the nerves of the upper limb. And the lumbosacral enlargement is going to give rise to the nerves of the pelvic region and lower limbs. The cauda equina, do we have anyone here who's a horse person? Likes horses?
Me, I have a horse.
You have a horse? My mom likes horses too. What? Equine, as I'm saying it all wrong. What does equine mean?
It means horse.
Yep, it means horse. So cauda means tail. So this looks like a horse's tail. And it really does. You look at pictures of it on Google of cadavers, it does. It gives rise to a bundle of new nerve roots that occupy the vertebral canal from L2 to S5. You understand the L2 and S5. If you remember your cervical vertebrae and each of your vertebrae along this column, cervical vertebrae, thoracic vertebrae, lumbar vertebrae, sacral vertebrae. And all of this sacral vertebrae fuse to form the sacrum. So with that in mind, each of the spinal pairs, each of the spinal nerve pairs are going to exit the spinal cord through the intervertebral foramen, which is a hole that's made up by the top of one vertebrae and the bottom of the adjoining one, the adjacent one. So the spinal nerves are divided into 4 regions named for the level of the vertebral column in which they arise. The cervical spinal nerves, the thoracic spinal nerves, the lumbar spinal nerves, and the sacral spinal nerves. And there's one coccygeal nerve. There's 8 pairs of cervical nerves that are going to control the sensory and motor activity of the head, the neck, the upper body, the arms, and hands. How many cervical vertebrae are there?
7.
Right, so there's 7. So how do you get 8 spinal cervical nerves? If there's 1 per vertebrae, how do you get 8?
One of them has to have another set, maybe the atlas.
I think you're right. Yeah, I'm sorry, you're right. It's the atlas. And it actually is going to come up from on top. So all of the others are going to come out via the intervertebral foramen underneath. And I really should put a picture of this in here. Bear with me. Would save me time. But let me show you really quick. Intervertebral. Intervertebral foramen. Now I'm going to do one here. This is a good picture. So right here, looking at it, here's the one vertebrae. It joins with the next vertebrae. That intervertebral foramen is right there, which is where the spinal nerve is going to exit. So with regards to the C1, C2, there's an additional one. So let's say this is L1. This is going to be the L1 spinal spinal nerve. C1 is going to have one that's going to actually exit up here, and then C2 is going to be here. C3, C4, all the way down. So it's actually going to have C1 up here and C2 here. That's the only difference. Is that clear? So there's 8 pairs of cervical nerves. There's 12 pairs of thoracic nerves that are going to control the sensory and motor activity of the hands, the fingers, the chest, and the abdominal muscles. The lumbar nerves are going to control the sensory and motor activity of the hips, the knees, the ankles, and toe muscles. The sacral nerves are going to control the sensory and motor activity of the legs, the toes, the bladder, and the anal muscles. And there's 1 pair of coccygeal nerves. If you remember when we talked about the nervous system in chapter 12, it does not undergo mitosis. Neurons don't undergo mitosis. You're born with all the neurons you're going to have in the central nervous system. And so that's why damage to the spinal cord and the brain is so traumatic, is because they're really not reversible. Once it occurs, it's done. Therefore, one thing that we have in the central nervous system is we have a lot of protection. So we have both vertebrae, bony bones, and we have the meninges. So the first level of protection for the spinal cord are the vertebrae that provide this strong protective defense. Also, we have meninges. These are 3 protective fibrous connective tissue membranes that enclose the brain and the spinal cord. From superficial to deep, so from the top surface down, the mnemonic that I use to remember these is DAP. Dura mater is the most outer layer. Arachnoid mater is the most inner layer. Assuming the middle layer. Pia mater is the most inner layer. The dura mater surrounds the spinal cord and it's separated from the vertebrae by an epidural space. The arachnoid mater adheres to the dura and is separated from the pia mater by fibers spanning the subarachnoid space. You guys, what does arachnoid mean?
Spider.
Spider. So arachnoid mater looks like a spider web. It's It's a webbing. So it's a webbing that's going to adhere to the dura, and it's separated from the pia by fibers that span the subarachnoid space, which is filled with cerebrospinal fluid. So, and when we say subarachnoid, we're saying the space right underneath the arachnoid mater. Epidural meaning the space above the dura mater. Subarachnoid meaning the space below the arachnoid mater. So the space in between the arachnoid mater and the pia mater is filled with cerebrospinal fluid. And this space is called the subarachnoid space. The pia mater is a delicate membrane that's composed of one or two layers of squamous to cuboidal cells. It's one or two layers is how thick is one or two layers of cells?
Like less than a piece of paper?
Less than a piece of paper, and it's even probably less than it's less than a piece of paper. It's transparent because it's so thin. So it's a delicate membrane composed of one or two squamous to cuboidal cells, epithelium, with collagenous and elastic fibers with blood vessels that supply the nutrients. Denticulate ligaments are thickenings of the pia mater. And one thing that I should say here, the pia mater is the immediate surface on the cord. So you're not gonna, if we were looking at a spinal cord, you're not gonna actually see it because you're gonna be seeing through it. You're gonna slough it off before you realize that you've sloughed it off. So it's right on the surface. A lot of times, if you ever take an exam using a cadaver, they like to pin the top of the spinal cord or the surface of the spinal cord or the surface of the brain and say, what is this layer? It's the pia mater. So denticulate ligaments are thickenings of the pia mater that suspend the spinal cord in its dura mater sheath. Here's the dura mater sheath. Here's the denticulate ligaments. Here's the pia mater. And this right here, this layer that's right here is the pia mater because you're seeing right through it. So we have these subarachnoid spaces and these epidural spaces. These are spaces that are not, I told you that the meninges are continuous with the spinal cord and the brain. We do not have these spaces. It's kind of an epidural, no, we don't have an epidural space. We have a subarachnoid space, but we do not have an epidural space. Do we have an? You know, before I say we have a subarachnoid space, I need to think about that. Yeah, we do. We have a subarachnoid space. We don't have an epidural space. Can a space be created? Yes, if they get bleeding, it'll create a space between the vertebrae and the dura mater. And sorry, between the cranial bones and the dura mater. But unless it's created there by bleeding or pressure or fluid, it's not going to be there otherwise. So the epidural space in the spinal cord contains blood vessels, adipose tissue, and loose connective tissue. The subarachnoid space like the subarachnoid space that's going to be around the brain, contains circulating cerebrospinal fluid, which cushions the spinal cord and delivers nutrients and removes waste. A lumbar puncture or a spinal tap is a sampling of the cerebrospinal fluid from the subarachnoid space to look for bacteria, blood, white blood cells, or other abnormalities. It's most often used to diagnose meningitis, but it is used to diagnose other diseases also. What they do when someone is having a spinal tap done is they have them curl up in a fetal position. And then they insert a needle between the L3 and lumbar L4 vertebrae and pull out a small amount of the cerebrospinal fluid. Afterwards, they make them stay curled up in that position for quite a while. Why do you think they do that?
Headaches.
Why do they get headaches?
Can it cause like a spinal fluid leak?
I'm not sure if they can cause a spinal fluid leak. They might. I had a student a year ago or something who they finally realized why she was having chronic migraine. She was having spinal fluid leaks, cerebrospinal fluid leaks.
When we do any sort of like epidurals in the office with like, well, upstairs in the surgery center, they can get a leak and they usually get like a really bad headache and we have to do a blood patch on them in the hospital.
Oh, really?
Yeah.
I see. You know more than I know, Sarah. I didn't know that. Why else? The reason that I was told why they have to stay in that position is because the cerebrospinal fluid, it's a pressurized space. You pull liquid out of there, your brain is floating in it, your spinal cord is floating in it. When you pull it out, that volume has to be taken up with more fluid before someone is up and standing again.
Yeah, that makes sense too. Yeah.
So I think we're both right there. No, I didn't know that they can actually, that can cause a cerebrospinal fluid leak. I didn't know that. Always learning something new. You guys are so smart. It's like talking with my mom all the time. Because she understands that kind of stuff. And I know anatomy and physiology. I don't know a lot about patient care sometimes. So agents such as drugs, chemotherapeutic agents, and analgesics and contrast media can be injected into the subarachnoid space also. An epidural injection is what it sounds like. A needle is inserted into the epidural space, which is superficial to the dura mater. So you're very, very low risk for puncture of the spinal cord. I know it's happened, but it's so rare. So anesthetics are sometimes used to introduce to this space to block pain signals during childbirth or surgery. And it's in that same area. As the spinal tap. So looking at a cross section through the spinal cord, the central area is gray matter. You remember in chapter 12, we talked about what gray matter is. Cell bodies, dendrites, and synapses with very little myelin. It's a site of information processing and synaptic integration. White matter is myelinated axons, carrying signals from one part of the central nervous system to another. So a bundles of axons called tracks that are going to carry signals from one level of the central nervous system to another. When we talk, as we continue here, think of the fact that ultimately we're creating a roadmap from the peripheral nervous system through the spinal cord to the brain. We'll talk about the destinations of those roads later. But right now, understand that we're creating a roadmap. We have roads that go go down. We have roads that go up. We have roads that are going to exit the spinal cord. We have roads that are going to enter. And sometimes they're adjacent to one another. Sometimes they're not. So tracks are our roads. In the central nervous system. Nerves are our roads in the peripheral nervous system. So the spinal cord has this central core of gray matter and white matter surrounding it. Within the gray matter, we have a posterior gray horn. Here's the posterior side, anterior side of a posterior gray horn. From the spinal nerve area of T1 to L2, we have a lateral gray horn. We only see it there. So we only see it in cross section when we're looking from T1 to L2. And then we have an anterior gray horn. The posterior or dorsal horns, remember posterior and dorsal are the same thing. They both are referring to the back. Posterior and dorsal horns are carrying the posterior roots of the sensory fibers and cell bodies of interneurons. So information, sensory information, afferent sensory information is going to come in through the dorsal posterior horn. The anterior ventral horns carry the anterior root of the spinal nerve of the motor fibers, so the efferent fibers. The gray commissure is going to connect the two sides of this spinal cord. And within the gray commissure is a central canal that's lined with ependymal cells. Do you remember what ependymal cells are? They're one of the neuroglia in the central nervous system. And their job is to secrete cerebrospinal fluid. The lateral horn that we only see from T2 to L1 contains the cell bodies of motor neurons of the sympathetic or visceral nervous system. So the fight or flight part of the autonomic nervous system. The white matter of the spinal cord surrounds the gray matter, and it's bundles of axons that go up and down the spinal cord, allowing for communication between different levels of the central nervous system. these bundles are arranged in 3 pairs of funiculi, aka columns. They call them white columns or funiculi. Your book calls them funiculi. If you're using the Wiley Lab Manual with Joe Bacon, they call them white columns. So we have these bundles that are arranged in 3 pairs. We have a posterior funiculi back here. We have a lateral funiculi right here. And we have an anterior funiculi up here. There's subdivisions in each of these funiculi that are called tracts. Remember, those are our bundles of myelinated axons. So they're subdivision in each of these funiculi. They're subdivided into myelinated axon tracts. We also call these tracts fasciculi. All these funny words, but you'll see that we're going to see them over and over again. So all of the fibers in a given tract have a similar origin, destination, and function. The ascending tracts that move up the spinal cord are going to conduct sensory nerve impulses up the spinal cord toward the brain. Remember how they're entering through the dorsal root. The descending tracts are going to conduct motor nerve impulses down the spinal cord from the brain. Sensory and motor tracts in the spinal cord are continuous with the sensory and motor tracts in the brain. Remember, we also call these same tracts, we call them afferent and efferent tracts. Afferent meaning incoming, efferent meaning outgoing. Sensory is incoming, efferent is motor. And the motor is going to, those nerves are ultimately going to exit the spinal cord via the anterior horn and root. So each of these tracts, remember these are our roads, each of these tracts carries specific types of information from one location to another. So if you want to carry painful stimuli from the spinal cord to the brain, you're going to use one particular tract, the spinal thalamic tract. Well, if you want to carry voluntary movement commands from the brain to the spinal cord, you're going to use the lateral corticospinal tract. So this is ascending, the pain fiber, the pain sensations. This is descending, the lateral cortical, because it's motor. If you look in your book, there are lots of more tracts. These are the ones we're going to focus on. We're not going to worry about the others. Some of the tracts undergo decussation, which means that they cross the spinal cord at the midbrain. Sorry, they cross the midbrain. So, I keep messing it up. They're going to cross the spinal cord. So the brain is going to sense and control the contralateral or opposite side of the body. So these tracks are contralateral, meaning their origin and destination are on opposite sides. Some tracks do not decussate, so they're ipsilateral, meaning that the origin and destination are on the same side of the body. Ascending track. So remember, this is one of these is your spinal thalamic tract. Ascending tracks travel across 3 different neurons from origins to destinations in the sensory areas of the brain. We have a first order neuron, which is going to detect the stimulus in the peripheral nervous system and transmit the signal to the brain or the spinal cord or brainstem. Right here. Of a second order neuron, which is going to continue from the thalamus. It's going to start in the brain, in the spinal cord or brainstem, and it's going to continue to the thalamus, which is in the center of the cerebral hemispheres. So cerebral hemispheres. The third order neurons are going to carry a signal from the thalamus to the sensory region in the cerebral cortex, this outer layer. Cortex always means an outer layer. So the outer layer of the cerebrum or the cerebral hemispheres is the cerebral cortex. So first order, transmit the signal to the brain, why do I keep saying that? Transmit the signal to the spinal cord and the brain. Second order neurons are going to take the signal from the spinal cord or brain stem to the thalamus. The third order neurons are going to carry the signal from the thalamus to the sensory region of the cerebral cortex. Questions? Within this ascending track, we have in the posterior funiculus, remember that's one of the white matter columns, and it's the posterior one. We have 2 fasciculi, so 2 different tracks that convey sensory information for discriminative touch, light pressure, and conscious proprioception. The gracili fasciculus is going to convey sensory information from the sacral and lumbar areas to your brain. So the lower part of your body, including your legs, lower half of your body. The cuneate fasciculus is going to convey this same discriminative touch, light pressure, and conscious proprioception from the thoracic and cervical body areas to your brain. So it's the upper part of your body, upper half. Both of these fasciculi are composed of first order nerve neurons that are going to travel up the spinal cord. So they both of these fasciculi are going to convey sensory information with regards to light touch, light pressure, and conscious proprioception. The gracilis fasciculus is going to do the lower half of the body from the sacral and lumbar areas. The cuneate fasciculus is going to do the thoracic and cervical parts of your body. So light touch, pressure, and proprioception senses, which are proprioceptive senses carried out by muscle spindles and other sensory receptors, are carried through these pathways. Okay, the biggest word there is proprioception. What in the world is proprioception?
It's when your body, even though like you're not looking at something and processing it that way, it knows, like if you put your arm behind your back, your brain knows where it is.
Claire, that was awesome. Where did you learn that?
Psychology.
That's awesome.
Yeah.
So
And
she,
I'm a massage therapist too, so I learned it somewhere along the way, also formally, but probably in massage school.
that's awesome. So she's right. It's being able to locate your joints in space without seeing them and without being consciously aware of them all the time. So looking here, I can move my joints and keeping my eyes closed, I know whether I've extended my arm or whether I flexed it. Somebody else can come behind me and do the same thing, and I'll still know where my joints are with my eyes closed. If you think that's kind of important, because it helps you maintain your sense of balance and your sense of location and overall well-being. So proprioception is this non-visual sense of the position and movements of the body through muscle spindles that are receptors in your joints. So in the posterior funiculi, we have that gracilis fasciculi and cuneate fasciculi. In the anterior and lateral funiculi, we have this spinal thalamic tract, which is going to transmit sensations of pain, warmth, coolness, tickling, itching, and deep pressure. If you've probably heard this before, that tickling is actually a sensation of pain. Itching is also a sensation of pain. It's a sensation of healing. And you know how you have a wound or a cut or something, and it gets kind of itchy, and they tell you not to scratch it. So think of the spinal thalamic tract as being specific for pain, temperature, and deep pressure. It's made from second order nerve fibers. Remember, these are going from the spinal cord of the brainstem to the thalamus. Due to the crossing of the second order neurons, the signals are sent, they decussate to the contralateral side of the cerebral hemisphere. the decussate. Any questions about these ascending tracks? So in the descending tracks, is a conduction of the motor signals down the brainstem and the spinal cord. The upper motor neurons are going to originate in the cerebral cortex or brainstem and terminate on a lower motor neuron. And think of termination as synapsing. So it's going to originate up in the cerebral cortex and move down and terminate on a lower motor neuron in the brainstem or spinal cord. The lower motor neuron cell body is in the brainstem or spinal cord. And the axon of the lower motor neuron is going to lead out to the muscles or other target organs. So it's going to be what's going to come out via the spinal nerve. Taking my teaching assistant. The lateral corticospinal tract is going to conduct impulses via these upper and lower motor neurons from the cerebral cortex of the brain to the spinal cord for voluntary movement of the skeletal muscles. So if your brain decides that it wants to move your legs, wants your legs to move, it sends this voluntary command from the brain down to the region of the spinal cord that's responsible for leg movements using this tract. Which of the following is true concerning the spinal thalamic tract? The spinal thalamic tract terminates in the spinal cord. The spinal thalamic tract begins in the thalamus of the brain. Spinal thalamic tract is found in the gray matter of the spinal cord. Spinal thalamic tract carries motor information down the spinal cord. Spinal thalamic tract is composed of multiple axons carrying information in the spinal cord. Now, first, it's made of first order neurons. And first order neurons terminate, they're within the spinal cord. They terminate within the spinal cord or the brainstem. So that is why the number A is correct. One thing that you can do here is use a process of elimination. Actually, wait, I think I was wrong. Bear with me. I'm so sorry. It's second order neurons. I thought that isn't right. Second order neurons. So use a process of elimination. It begins, so second order neuron. So it starts in the spinal cord and it terminates on the brainstem or the thalamus. So with this in mind, is B correct? No,
I
because
would
it
say
term-
no, because
No,
it's
terminates at
that doesn't begin at the thalamus.
yeah, it terminates there. So B isn't correct. Does it terminate in the spinal cord? No, because it starts in the spinal cord. So A isn't correct. Is it found in the gray matter of the spinal cord? What are tracks?
Myelinated axons.
So it's not gray matter, right? Because that's white matter.
It's white matter, yeah.
So C isn't correct. The spinal thalamic tract carries motor information down the spinal cord.
Isn't motor information up?
Yeah, so that's not correct either. So it's really spinal thalamic tract is composed of multiple axons carrying information in the spinal cord. So a lot of these types of questions, answer them via a process of elimination. Is that correct? No. Is that correct? No. Then that has to be correct. Amyotrophic lateral sclerosis, or ALS. How many know who this person is?
I forget his name.
Stephen Hawking.
Yes.
Is Stephen Hawking. So he's my, I idolize him in a lot of ways. And he just passed away about 2 years ago. So approximately. But I idolize him. And I think he was pretty amazing. And he was diagnosed at about the age of 21, 22, somewhere right in there, with ALS, and was told that he had about 2 years to live, 1 to 2 years to live. And obviously he died a lot older than 24. I'm trying to remember just how old he was. I think he was around 68, somewhere in there. So we've learned since his diagnosis that there's 2 types of ALS. There's early onset and there's late onset. Late onset, they can die within years to months. Women are more likely to die faster than men. It's characterized by the progressive degeneration of motor neurons in the spinal cord, brain, and motor cerebral cortex. So think your lateral cortical spinal tract. What occurs is that what they understand so far is that the neurotransmitter glutamate increases. And it's an excitatory neurotransmitter. So it gradually causes a sexually excitotoxicity of neurons. Which it occurs consequently with an accompanying rise of intracellular calcium levels. Well, what's calcium involved in? Or calcium's involved in the release of neurotransmitter. And so it becomes neuronal, the glutamate eventually becomes toxic. And there's an accompanying rise of intracellular calcium in conjunction with the neurotransmitter accumulation. Eventually the dendrites of the cells will be destroyed. Now, why would that be a bad thing? What do the dendrites do?
They don't regenerate, correct?
Well, the neurons in general don't regenerate. Dendrites actually are pretty plastic. They actually, I think, I don't know if I shared you with this, but my hearing, because I'm hearing impaired and I wear a hearing aid, and I don't wear one when I'm have classes at home because noises tend to distract me really easily. So noises around my apartment and house will distract me. So I don't wear it in my house and I can hear you fine. But when I wear a hearing aid, the dendrites of the neurons within the ears become more sensitive because they increase the number of dendrites they have over time. The more I stimulate them, the more dendrites will develop. If I stop stimulating them, the dendrites will go away. They reduce in number. They don't go away completely, but they reduce in number. So I hear, when I'm wearing a hearing aid off and on, I still hear better than I do when I haven't had one for a really long period. So with that in mind, why are the dendrites, why would destruction of the dendrites be so bad?
Wouldn't they like not be able to receive signals then?
Right. Why, Brianna?
I don't know, they won't just be able to receive signals from other neurons.
That's kind of that, yeah, because dendrites are the receptors, right? They're the kind of feelers that are out there synapsing with things and bringing in the signal. So if they're not able to actually synapse with other neurons or other components, well, there goes our signal. So that's how ALS occurs. And remember, it's I don't know if I mentioned this, it's also Lou Gehrig's disease. So moving on, do you guys have any questions first before I just keep jumping forward? Slippers on my feet and I just gave them up. Nerves. Remember that out in the peripheral nervous system, we call tracts, we call nerves in the bundles of axons in the central nervous system is called a tract. Bundles of axons in the peripheral nervous system is called a nerve. So a nerve is a cord-like organ composed of numerous nerve fibers, axons, bound together by connective tissue. The most outer layer is the epineurium. That surrounds a bundle of fascicles. Where have you seen the fasciculi and fascicles before? We saw that when we were looking at the white matter in the spinal cord. So the epineurium is a connective tissue sheath that's going to surround a bundle of fasciculi, and within each fascicle, fasciculi being plural for fascicle, each fascicle is going to be surrounded by perineurium, a connective tissue sheath. Each fascicle is going to be a bundle of nerve fibers, aka axons. And around each myelinated axon is the endoneurium, another connective tissue sheath. So epineurium around a bundle of fasciculi. Around each fascicle bundle, which is a bundle of axons, is the perineurium. Around each myelinated axon is the endoneurium. So the endoneurium is a loose connective tissue that's external to the neural lemma. Do you remember what the neural lemma is? It's the most outer layer. Claire, what is it? I thought I saw you nodding your head.
I did. It's part of the nerve like tissue.
What part is it? Do you remember?
The nucleus.
You're
don't know.
close. You're close. If you think like a sarcolemma, we haven't talked about that, but that's the outer connective tissue of a muscle fiber, which is also a muscle cell. Neural lemma is the most outer layer of the myelin coat. Remember, we talked about axolemma, which was the membrane, the cell membrane around the axon. So neural lemma is the most outer layer around the myelin coat, myelin sheath. So endoneurium is the layer right external to the neural lemma, which is the most outer layer of the myelin. The perineurium are layers of overlapping squamous cells that wrap fascicles, bundles of nerve fibers. Epineurium is a dense, irregular connective tissue that wraps around the entire nerve. It's around the bundles of fascicles. So epineurium around the bundles of fascicles, perineurium around each fascicle, which is a bundle of axons, nerve fibers. And endoneurium is around the myelin of each fiber. So nerve fibers in the peripheral nervous system are surrounded by schwann cells forming the neural lemma and the myelin sheath. There's also blood vessels that penetrate the connective tissue coverings to provide an plentiful blood supply to service the high metabolic activities of these nerves. For a long time, I studied, I'm watching my time here. I studied, one of my things in my second master's that I did was to look at peripheral neuropathy. So loss of nerve conduction in the peripheral nervous system. And one of the major things that they're seeing with regards to peripheral neuropathy is that it's a loss of the nerve, but it starts with a loss of the blood vessels around the nerve. Anti-angiogenic drugs are drugs that specifically inhibit, we use them for chemotherapy drugs that specifically inhibit blood vessel development will often can cause peripheral neuropathy. Because these are what are supplying nutrients and eliminating waste from the myelin. And when you remove that, the myelin dies. A lot of reason type 2 diabetes deal with peripheral neuropathy, because it's a chronic inflammation. And oftentimes what they're seeing is it's reversible. If you can promote blood vessel development in the myelin, you can reverse the neuropathy. Very cool studies. I thought it was absolutely incredible. Because I thought, you know, you don't think about it that way, but that's the way it works. So different types of nerves. We've talked about these before, but this is kind of a good review. Sensory afferent nerves carry signals from the sensory receptors to the central nervous system. Remember, they're coming in through the posterior dorsal horns. Motor efferent nerves are carrying signals from the central nervous system to the muscles and glands. Mixed nerves are carrying signals from both the afferent and the efferent fibers. Both sensory and motor fibers can also be described as being somatic, meaning a voluntary. Remember, we call the somatic nervous system is your voluntary nervous system, the one that you're aware of. Visceral tends to be more autonomic. General and special. Visceral is also organs. General and special. So I'm going to come back to it. I should, yeah, let me look. Wait. Actually, yeah, I think I'm gonna go through this first, and then I'll keep going forward for a second here. Afferent fibers are carrying sensory signals from receptors to the central nervous system. Efferent fibers are carrying motor signals from the central nervous system to the effectors. Remember, these are coming in via the posterior horns or the dorsal horns. These are coming in via exiting through the anterior horns or anterior roots. Somatic fibers are going to innervate the skin, the muscles, skeletal muscles, bones, and joints. I like to think, if you think muscles, skin on top of muscles and bones and joints. Visceral is going to be blood vessels, glands, and viscera. Viscera meaning internal organs. General fibers are going to innervate widespread organs such as muscles, skin, glands, viscera, and blood vessels. Special fibers are going to innervate more localized areas in the head, including the majority of your special senses, your vision, your hearing, your smell, your taste, muscles of chewing, swallowing, and facial expression. And I know we're coming down to the end. I want to go over this slide first. Actually, you know what? I think we're gonna end right there. Because I want to this is going to relate to this down here. Do you have any questions for me? Okay. We will come back to this. My goal is to finish this. I want to finish looking at the spinal cord and start on the brain next time. And so your second exam is going to be after we finish chapter 14. So this is chapter 13. And we will do chapter 14, and then your exam will start that day. Let me know if you have any questions.
Will we have like a couple of days to take the exam like last time?
Yes, you'll have a week.
Okay, thank you.
Yeah, I'm not, you never know when someone's going to deal with internet outages and fun stuff like that. So you'll have 2 attempts. Your highest score will be the one recorded, and you'll have a week. Have a wonderful 2 days.
Thank you as well.
You too, thanks.
Thank you.
Thank you. Bye-bye.
Bye. Kevin, are you there?